Okay, today we're going to talk about leak tests and what they mean, why we do them, and how we do them. So our policy says that you have to do a leak test on your patient, determine what amount of pressure is required to seal the airway once a shift and 4 hours before extubation. Policy also says that you're to use no higher than 30 centimeters of water pressure when evaluating how much pressure it actually takes to produce a leak around the airway, which is between the artificial airway and the tracheal wall in most cases. So let's talk about what does that actually mean? Why do we want to know that information? Well, first of all, typically what we're going to have is if we have a cuff endotracheal tube in an airway, like depicted like this picture, what we're going to do is our cuff policy says without orders, we're going to address and inflate that cuff, whether it be air or water, enough that it seals the airway. And what we're doing is we're going to call that minimal occlusion volume. That's what our policy covers. So minimal occlusion volume is what we're trying to obtain on all our airways unless otherwise directed from the physician. And what that means is you have this pilot balloon coming off of this cuff, and what we're going to do is we're going to add air or liquid in this cuff so that the pressure that we're trying to ventilate at, let's say it's positive 20 of pressure that's coming out below the airway, that means based on our zero flow I-time policy, that means that 20 of pressure is going to be below this cuff right here at some point at the end of inspiration, for sure. By the end of inspiration, 20 of pressure is going to be realized below that cuff right there. So that means if the leak that occurs between the cuff and the trachea, if the pressure that it takes to push air through that gap is higher than 20, it's going to push through, and that as it pushes through that cuff, it's going to create a sound, which is the leak that we're listening to in the, over the anterior neck region. We're listening for the leak. And we're inflating this cuff so that if we're giving a PIP of 20 to the patient, that means we probably have to inflate this cuff so that it pushes on the tracheal wall with a force of 20 centimeters of water. It has to have that 20 centimeters of water here, otherwise a leak is going to occur. Once we get that pressure on the tracheal wall from the cuff itself at 20 or higher than 20, now this 20 is trapped below the cuff and can't exit through that opening because it's sealing it off at that pressure. And that's where we measure how much pressure is it taking in the cuff, and how, to keep that leak from occurring. Okay, that's our normal practice. Now, so we measure when it's air filled, we measure what pressure that takes to get that seal to happen. And in normal, almost, most patients, it should be equal to whatever their peak airway pressure is. That's how much air it should take. That's how much pressure in the cuff it should take to seal that. Well, let's say when we're doing this cuff, we have to have 30 centimeters of water pressure in there when our PIP on the vent is actually 20. But it takes 30 centimeters of water pressure in our cuff as we measure it with our cuffilator to seal the leak. Does that mean there's 30 centimeters of water pressure outside the cuff because we're measuring 30 inside the cuff? Well, no, that's not what that means. We know that by listening, that when the leak goes away, that this pressure at the tracheal wall has to be 20 or higher, right? But if we're doing our technique right, we're inflating the cuff just until that leak goes away. When that leak goes away, we stop. And if it requires 30 centimeters of water pressure, internal cuff pressure, to seal that 20 external, that means that usually the airway that has been placed in the patient is too small. Basically what will happen is you're stretching the cuff past its normal limits and you're pushing it larger so it can just make contact with the trachea here. And it's taking 30 of pressure inside the cuff to get it to touch the tracheal wall, if you will, and produce a force of 20 below the cuff itself, right? So when this happens, we're to notify the physician that this is happening, because almost exclusively the problem would be caused from an airway being too small. Let's say they put a for cuffed endotracheal tube in like a 12-year-old kid or an 8-year-old kid or whatever it is. It's not the right size airway for the patient. A lot of things could happen. It could be the right size for the age, but he could have an enlarged tracheal wall. I mean, there's abnormalities that would cause this, but ultimately the airway could be too small for the patient's airway. So we're requiring more pressure in the cuff. Another thing that's less common would be tracheal malacia, right? So if, let's say, this patient's tracheal wall at this cuff area is malaged. I don't even know if that's a real word, but let's say it is, right? So that means tracheal malacia. Malacia means like it's a floppy airway. It's not holding its tone like it normally would or you would expect it to. So that cuff basically would push that floppy tissue or the tracheal area right here, and it would basically just push it away. So instead of being like a rigid resistance to that cuff and holding its place, the malacia area, which happened to be right in the cuff area, would give as you inflate it, and the leak would still be there because it wouldn't resist that pressure. So you would need more and more pressure in the cuff to get that seal of 20 below it. And that's one side effect of having like tracheal malacia with cuffs and how we manipulate them. Okay, so that's how we do our cuffs. Now, let's say we go over to this airway, right? So now what's happening here is this is a cuffed endotracheal tube in the trachea as well, but the cuff is all the way deflated, right? So here's your cuff, we measure it and the pressure is 0, okay? So we have 0 pressure in our cuff. We have the cuff deflated and he's on positive pressure ventilation and his peak airway pressure is 28 centimeters of water pressure. Or let's say it's 20, let's forget 28, let's say it's 15. Let's say he's pretty compliant, right? So we know that at a 15 of PIP, we do not have a leak around this cuff, right? Because we have the cuff deflated and there's no audible leak, which when we listen with our stethoscope. So we know that the leak is somewhere above 15, but we don't know if it's 16, 17, 18, 19, 20, 28, 50. We have no idea, right? Here comes our leak test, right, that we're gonna do. So we're gonna manage this with the cuff staying deflated because there's no leak, and that's our leak, our cuff practice of minimal occlusion, which we'd have it deflated, but we need to know what leak is occurring, because if this kid's leak is actually occurring at, say, 18 a PIP or 16 a PIP, anything less than 20 centimeters of water pressure, the odds are favorable that when we pull this tube out, the trachea has not been stented to a degree it's going to rush blood into it and occlude the airway, right? The odds are that that's not going to occur. It can still occur, but it's less likely if the leak is below 20 centimeters of water pressure. However, if we do our leak test on this trachea and we find that the leak is at, say, 28, it has to go all the way to 28, which we're going to show in a minute, before we hear a leak, that decreases the odds that when we pull this tube, he's not going to have his blood rush into this airway, his tissues fall into itself and cause stridor and possibly respiratory distress from it, okay? So we do this, we measure it, and if it's above 20, say it's 25, 26, we notify the physician as such, and maybe they decide to start steroids on this patient, anticipating that that could happen, so we're going to give some steroids before we actually pull the tube. Okay, so how are we going to determine at what pressure does this leak happen? First of all, when we talk about leaks, we're talking about audible leaks. We are not talking about leaks on the waveforms. Leaks on the waveform is another thing, right? Leak on the waveform means many things. It doesn't always mean a leak around the cuff. It can mean lots of things. So that's why we don't exclusively look at the waveform for a leak. We listen. We start with the listening. If we don't hear a leak in the anterior neck, but we have a leak on a waveform, now we know it's not the cuff that the leak is coming from. We can work our way through the circuit in the patient to find other leak areas. Okay, so how are we going to do this leak typically? So we're gonna come over here and I have this mannequin